So there were two studies, global report heart failure registry, and 43% of the patients had de novo heart failure. Now the range was around 20% in North America to around 80% Southeast Asia, but around 40-45% patients were had de novo heart failure. Similarly, in the PREVENT study, 66% of patients were newly diagnosed heart failure with reduced ejection fraction patients. So de novo heart failure is an increasing challenge, and ARNI keeps de novo heart failure patients out of the hospital and helps them live longer. Now you remember that if the patient is hospitalized for heart failure, there is a very high chances that he might get re-hospitalized within first 3 months. And I think this vulnerable period is a very, very important period, and there is a significant lower incidence of composite of cardiovascular death or heart failure re-hospitalized in de novo heart failure patients with HFrEF, especially when they started on ARNI. So we want to prevent that re-hospitalization and acute decompensation, rather, or de novo heart failure decompensation. That's why we start an ARNI earlier in a patients. There was a transition study also, which compared the initiation of ARNI shortly after hospitalization for acutely decompensated heart failure in patients with newly diagnosed or de novo heart failure. And this study also suggested that you should start ARNI early, ideally before discharge. You see, ARNI improves cardiographic parameters in de novo hospitalized patients. Like there was a reversal of remodeling. Now, the drugs like beta blockers also have helped ejection fraction by around 4 to 5%, maybe ACE inhibitor by 1 to 3%, 1 to 4%. But ARNI improved the ejection fraction by around 14-15%. And more importantly, the remodeling also was improved. Now, remodeling is very, very important, especially the LV and diastolic volume, rather LV and systolic volume is even more important than LV and diastolic volume. LA volumes, E by E prime ratio, all these parameters, and including the NT-proBNP levels, they actually improve within starting of the ARNI. Also, the troponin T concentrations, the highly sensitive troponin T concentrations also were reduced, rather normalized once the patients were started on ARNI. More de novo than prior heart failure with reduced ejection fraction patient achieved target dose at week 10, 56% versus 45%, if you can look at this. So the transition study, what are the results? First line initiation of an ARNI in de novo heart failure patients with reduced ejection fraction alongside the initiation of other guideline-directed medical therapy is feasible and is associated with a better risk profile. Early intervention with sacubitril valsartan should be considered to delay disease progression in patient with de novo heart failure with reduced ejection fraction. In fact, McMurray et al. And Milton Packer have also suggested that the 4 foundational drugs like ARNI, beta blockers, evidence-based beta blockers like bisoprolol or carvedilol or metoprolol, aldosterone antagonists, and SGLT2 inhibitors, these all 4 in the minimal possible dosages should be started as early as possible, ideally within 1 month of hospitalization. 2021 update to the 2017 ACEI expert consensus decision pathway for optimization of heart failure. Let's discuss that. So heart failure with reduced ejection fraction stage C. First of all, start an ARNI ideally, or an ACE inhibitor ARB. ARNI is preferred choice, along with the beta blocker, which is evidence-based, as I've mentioned, bisoprolol, metoprolol, and carvedilol, whichever. Then diuretics also. Now, if the patient does not have creatinine around, it is lesser than 2.5 and eGFR is more than 30, potassium is okay, you can always add an aldosterone antagonist. If the patient has eGFR, which is meeting the criteria, like less than 20 or less, maybe at least more than 20 or more than 30 as per DAPA or EMPA studies, the SGLT2 inhibitor can be added. For patient with still persistent overload or heart failure, diuretic dose needs to be increased. For patients being symptomatic despite the starting of ARNI, beta blocker, aldosterone antagonists, SGLT2 inhibitors, you can, especially in the black patients, you can use a hydrolyzine azoxystrobin combination. And for patients with, despite the maximal tolerated dosage of beta blocker, if the heart rate is more than 70, you can add evabrad to that as per the SHIFT trial, which shows 19% mortality benefit. So clinicians should aim to achieve optimal guideline-directed medical therapy within first 3 months only, I will say, at the most 6 months of initial diagnosis of heart failure. ESC 2021 guideline also recommends ARNI as the first-line therapy instead of ACE inhibitors in HFrEF patients. You can see in any patient with HFrEF, first line is class 1A recommendation is ARNI. If ARNI is not feasible, ACE inhibitor can be used. If patients are intolerant to ACE inhibitors because of cough or angioedema and ARNI is not feasible, then ARB can also be used, but preferably an ARNI is the first choice. And if it is not feasible, then only you use other drugs. Now,